Yeah, I think I will get started.
Yeah.
Um, so I will first introduce myself. So my name is Tamara Hoveling. I'm currently finishing my PhD at the Technical University in Delft in the Netherlands. So still a PhD candidate for a few more months. And my research topic is designing medical devices for a circular economy. And apart from that, I'm also co-founder of Nova Lilium. Not going in depth into this, but if you're interested in this topic, you can reach out to me. It's about a patient-friendly redesign of the vaginal speculum. But today about sustainability, the problem that we are facing is that healthcare's climate footprint is equivalent to 4.4% of global net emissions. That's a calculation from 2019. And we are zooming in on the perspective of medical devices. So I'm speaking today on behalf of TU Delft and the DICE project, which is short for Digital Health in Circular Economy. And well, I will provide a link to the project later on, but it's a Horizon project as well. So to solve this impact of healthcare, we need to make some changes because healthcare does save lives today, but its hidden pollution threatens the health of tomorrow. We see more and more digitalization coming up, so lots of devices that were previously manual will now be embedded with electronics, batteries, and at the same time, they're becoming more and more disposable. So where we used to reuse more, we now we now more often dispose of them after just using them once, or sometimes even without using them at all because they have been opened in the operating room. So all of this together, it makes sure that we have more mining, more waste. There's more scarcity, and we also run into critical materials, and of course increased CO2 emissions. And this is very important because as Healthcare Without Harm estimated in 2021, without action, the CO2 footprint of healthcare would actually triple by 2050. So we really need to make changes. Currently, we have a very linear system, which looks somewhat like what you see on the screen now. So on the left, we have the actual development of the devices. So, well, literally the medical device development process, then the production and use of the material, and the disposal. But we would like it to look more like this. So this is the visual taxonomy of circular healthcare flows that we developed over the past few years. Of course, there is an overview of our strategies already. So we all know the terms like reuse, remanufacture, that kind of things, but we did a wide research on how these terms are used in healthcare. For example, the term reprocessing, which we often use to describe medical devices that are, well, processed again to be used again, that's a word that's basically unknown in circular economy literature. So we looked into words that are used in healthcare and what is meant by them. And then we made this overview. I'm not going very in-depth into it today, but I just wanted to show you that it's a very complex system with a lot of options that are currently not being leveraged. So if you do want to know more about this one, you can, well, use this link to the full paper, which has the full literature review in there and the outcomes of it as well, with definitions and all. But this overview, as we would like it to be, is just not how it's currently done. So To give an example, we screened 1,400 medical devices that have electronics in them, so active medical devices from all over the world. And only 25% of them were employing at least one of the strategies that you see here. And almost all of those were reusable. And often the decision to reuse something was financial and not due to sustainability. And all the other strategies like recycling or, for example, reducing the number of times it's used or the types of materials used is way less common. And what we see is that where it goes a bit better with sustainability is smaller medical devices that are MDR class 2A, so they are not super low criticality, but also not super high. Those score the highest on, how many of them are reusable. And this is because they're very easy to handle. It's not like an MRI machine that you can not move. At the same time, they can be cleaned in hospitals. So those are the types of devices that go through sterilization cycles, like reprocessing cycles in hospital often. But yeah, as I said, we can still do much better. And we actually identified 31 distinct barriers to why medical devices are currently not fitting into a circular system as much as we would like to. And I want to highlight 5 of them. So first of all, the safety risk, of course, it's very typical for healthcare that we don't want to contaminate a next patient by using a previously used device. However, what's very important here to mention is that in many cases, the safety risks were actually perceived safety risks. An example of that I could give here is we saw the cleaning of endoscopes. They put on a new glove every step of the cleaning process and disposed of this glove. However, there was later proven that it was actually more sanitary in this specific cleaning process to use cleaned bare hands rather than gloves. But because we feel like putting on a glove would make it safer, we do use them. This is, of course, not a very high impact example, but I think if you are a bit familiar with healthcare, you know that we are rather safe than sorry. So we take a lot of precaution even when it's not needed. Then we have regulatory compliance. I will go a bit more in depth into that later. The technological limitations, of course, is mostly my expertise. There's a lot of devices out there that are not designed to fit into a circular system. They are not modular, and often sustainability or circularity are considered in later versions of the device rather than from the start, even though devices may last up to 10 years in some cases. So some things are really lacking behind. Of course, then you have financial constraints. We have a lot of linear business models, and we need implementations roadmaps rather than a sustainable North Star to make this feasible. And lastly, social acceptance. Even when we have the perfect idea and perfect system, we still need people to actually want to use it and trust it. These are just 5 examples, but other important ones I'd like to mention is that it's unclear who's responsible and there's no reverse supply chain in place. So in terms of responsibility, what I find interesting is that every single person I interviewed in the past 4 years about this topic, all of them at some point said something in lines of, well, that's not my responsibility, someone else should have taken this on. So we're blaming others rather than taking action. This comes from a paper about barriers, opportunities, and best practices from a design perspective. So you can also read this full paper if you think it matches your interests. So to go a bit more into the policy architecture, now this is not my point of expertise, but I will give a general overview on how I interpret it. So I see three different themes here. The first one is, of course, the medical device regulations. It's very focused on safety and liability logic. So, of course, we have the risk-based approval, post-market surveillance, that kind of things. This makes sure that devices are safe to use, but it also poses a reprocessing barrier. For example, in Europe, single-use devices can only be reused if allowed nationally, and the reprocessors may assume full manufacturer liability. Sorry. I do want to add here that I'm not very much in favor of single-use reprocessing, which is probably something that we can have a large discussion about. But I feel like it would be much better if we design devices to be reusable, with the intention to be reusable from the start, so that we actually know that it can safely be reused rather than having something intended to be single-use and then reuse it. Well, moving forward, we also have some regulations about circularity, and sustainability, like the eco-design regulations, and we have the Waste Framework Directive. They bring on requirements like durability, repairability, and substance control. So there is a certain design push that say that products should stay in the loop rather than be in a linear process. And lastly, of course, we have some climate pressure, like the EU Green Deal. For example, due to that, hospitals are expected to reduce their footprint via purchasing. So if you see all this together, it looks like we have some safety caution, but also some push to get it more into sustainability. But here's what actually is happening. So the MDR does not ban reuse, but it does effectively discourage it. So the combination of the certification burden and the legal risk makes reuse, for example, very hard to scale. Then we have eco-design that pushes for circularity, but it's not tailored to healthcare at all. So it's built around durability, repair, reuse, but then we have the medical devices that sit in a system that's just completely not designed for the circular flows or products just yet. So it's very hard to apply in context. And then we have the climate policy that really raises the pressure, which, by the way, is great, but it does not resolve the trade-offs. There are a lot of trade-offs, like financial trade-offs. There could be safety trade-offs, and they need to be resolved before we can actually respond to this pressure. So the main takeaway is that the EU policy doesn't block circular healthcare, but it does make it economically and legally irrational. So liabilities sit with reuse and incentives with disposability. And I will try to give an example. Now, this is a redesign, very conceptual, so it's not like something that's happening in practice. So I will leave out the technical limitations at this moment. But let's say this is a laparoscopic instrument used in minimal invasive surgeries. And currently, it's a device that's used once on one patient and then disposed of. In theory, reuse via reprocessing is possible, but it's heavily constrained. So there's, of course, the patient risk and everything involved. But we thought about how we could resolve this in a hybrid circular design. We saw that the highest impact of this device is the manufacturing of the electronic components. So what we would like to do is ensure that we can at least reuse the electronics. The electronics are inside the device, so they are in principle not sterile, they have no patient contact, and they can be completely safely encapsulated in the outside of the device. Now, the parts that are exposed to the air of the operation room or to the patient could, in theory, be sterilized if they are properly designed to be completely cleanable. And if not, they could be recycled or disposed of because they are not the highest impact of the device. Another idea we had is to make it multifunctional, because currently it could be that in laparoscopic surgery, you need different functionalities in one surgery, but not at the same time. So you could perhaps click on a separate functionality shaft on the same base device, due to which you need less devices and less electronics in general. And then, of course, the rechargeable electronics, as I just said. Oh, and we spoke to medical professionals and looked at their workflow, and we know that in a lot of contexts, this could actually work in what they are already doing. However, there are some key barriers that we encountered. First of all, it does not really clearly fit the approval categories because it's a hybrid device. So it has different functionalities that do not even happen at the same time. Then there is a compliance burden because changing the components may trigger recertification requirements. And even if it doesn't, for a lot of medtech companies, it feels like a risk to do this kind of design. Of course, in the hospitals, they also see a lot of procurement officers that optimize for the purchase price instead of the life cycle cost, which would make a big difference in this case. And even though we checked on the workflow, it is still built around single-use devices. So it does still need a change there. So from this example, I personally would argue that hybrid circular devices fail to scale not because they don't work, but because regulation and procurement are still designed for a linear system. So I want to show a little bit of the work we are doing to hopefully help enable medtech companies to change this from their own perspective. So we are developing in the DICE project a circular design guide for medical devices. And as I said, it's quite a complex system with a lot of considerations, but we try to simplify it as much as possible. So we are presenting a 5-phased approach. So have some step-by-step guidance to walk them through it, adding to the knowledge that they already have. And as I said, there's a lot of issues around who's responsible for what. So we want to include different roles to inspire collaboration and accountability to really connect tasks to different roles in the company. So I want to show some example pages, but those are really first concepts, so not a final result. So for example, for phase 1, this would be an introduction phase. So it would say like what the phase is about, which rules are involved, and which circular strategies are addressed in the steps. Then as a first step, we want to look into reviews. What we see currently is that a lot of technologies we're looking for ways to introduce cool, innovative techniques that we found. I come from a technical university, so I do see this happen a lot, rather than trying to solve an actual clinical need. Now, if we would say to a medical device engineer, like, does your device really have a place in this world? Do we really need it? If we ask it like that, anyone would say, yes, of course we need it. That's why I'm working on it. So we try to make it a bit more extensive with reflective questions on what is actually the added value of the product and how can we make sure that we don't introduce things that only adds to the environmental impact and then try to minimize it rather than just not producing it in the first place. So that's the intention of step 1. And then for step 2, we provide some guidance on how to determine what are the environmental hotspots and what to focus on in the design process. As an example, what I just said with the laparoscopic device, if you would focus on the electronics, that would be best because they have the highest impact. So we wouldn't focus on the recycling of the plastics. Of course, it's also important, but we need to set priorities. So those were the example pages. We have a lot more, of course, but for now, this is enough, I guess. But we're really deep into the development of the design guide, so we really need expertise from people in the field that can help us make the guide a success. So please, if you are interested in this guide and want to receive updates or offer feedback while we're developing, please reach out to me. This is my TU Delft email address. It's also listed here. And we also have the link to the DICE project on the bottom. And as I said in the beginning, I'm also involved in a patient-friendly redesign of a vaginal speculum. The presentation is not about this at all, but you might have seen it in the media somehow, even though it was not widely shared in Spain. If you want to know something about this, please use the other email address.